In this section, we will go over medications commonly given to patients who have asthma and chronic obstructive pulmonary disease, or COPD. In this section, we'll discuss medications that are used to treat asthma. It's important to remember that asthma has two major components to the way that it causes bronchoconstriction. It works through both inflammation and constriction of smooth muscle cells. These processes are caused by bronchial hyperreactivity, bronchospasm, increased mucus secretion, and cellular infiltration. It's important to treat the acute symptoms as needed, but the long-term goal for treating asthma is to treat the inflammatory process and prevent asthma attacks. This cartoon shows normal bronchial epithelium, as well as the lamina propria and the smooth muscle cells that are underlying the bronchial mucosa. In a patient that has asthma, you can see that this patient has a lot of mucus production, as well as eosinophilic infiltrate. The goblet cells, or the epithelium of the bronchial smooth muscle, of the bronchial tree, produces the mucus that is often overlying the cells. And the lamina propria is filled with white blood cells, and the glands have become hypertrophied, and the smooth muscle is also very thick and constricted. The major asthma medications that we'll be talking about are corticosteroids, beta agonists, muscarinic blockers, theophylline, cromolyn, and leukotriene antagonists. Inhaled corticosteroids are the cornerstone of chronic treatment for moderate to severe asthma. The way these work are by inhibiting white blood cells and preventing cellular infiltration and the release of inflammatory mediators such as TNF-alpha and interleukins. The most popular corticosteroids that we use that are inhaled are fluticasone and mometasone. When used appropriately, these have very few side effects. They can possibly cause oropharyngeal candidiasis because of a localized immunosuppression effect on the mouth and the oropharynx. With excessive use or systemic use, they can cause the classic side effects that you see with corticosteroids that we'll talk about. Corticosteroids are generally avoided in children with asthma because they can cause growth suppression. Something important to remember about inhaled glucocorticoids, and we see here a patient inhaling glucocorticoids, is that generally, across the board, only 10% of those steroids are actually deposited in the lung where they do their job. Most of the glucocorticoid is actually either swallowed because of improper use or because in the back of the mouth it drains into the esophagus. It is then absorbed in the gut, undergoes first-pass activation, or causes problems in the systemic circulation, leading to systemic side effects. This can be improved by using a spacer on the inhaler or by mouth rinsing after using the inhaler. Systemic corticosteroids involve oral and IV agents, such as prednisone and prednisolone. These are generally reserved for severe and persistent asthma. Some of the adverse effects with the chronic use of corticosteroids, as we've talked about before, are delayed wound healing, osteoporosis, alteration of fat distribution, striae on the skin, and disruption of glucose metabolism, meaning drug-induced diabetes. As you can see here, this patient who's been taking corticosteroids for a long time shows signs of facial plethora, hirsutism, moon facies, which means fat deposition in the cheeks, acne and cataracts, as well as buffalo hump obesity, as well as central obesity, abdominal striae, easy bruising, skin atrophy, and muscle weakness, as well as delayed wound healing. The next important category of asthma therapy involves beta agonists. Beta agonists are used for acute bronchoconstriction and for prophylaxis of exercise-induced asthma. These medications cause bronchodilation and open up the airways. These do not resolve inflammation. If used chronically, these medications can lose their effectiveness, except for salmeterol. We'll talk about that. Albuterol is a very commonly used short-acting beta agonist. This works on the beta-2 receptor, and it opens up smooth muscle in the lungs. Salmeterol is also a beta-2 agonist that is long-acting. Isoproterenol is a beta-1 and a beta-2 agonist. The short-acting beta-2 agonists include albuterol and terbutaline. These have very low potential for systemic toxicity if they're inhaled in an inhaler. However, overuse can cause beta-1 effects because these medications are not completely specific for beta-2. It can cause anxiety, tachycardia, and muscle tremors. These meds are usually given by nebulizer or systemically by IV for severe attacks. The long-acting beta agonists, or LABAs, include the prototype salmeterol, which is the most commonly given LABA. Salmeterol is used for chronic management, often in combination with a corticosteroid. It is not appropriate for acute asthma exacerbations in the emergency room. It should be used every day, twice a day. The next classification of asthma medication includes the muscarinic receptor antagonists, and these include ipratropium and tiotropium. You can remember that these are muscarinic antagonists because they almost look like atropine. These are longer-acting medications. Ipratropium is a shorter-acting agent. These medications are usually inhaled, sometimes in combination with beta agonists. The way they work is by blocking acetylcholine-related bronchospasm. They're also commonly used for COPD, or chronic obstructive pulmonary disease, such as chronic bronchitis or emphysema. These medications can have atropine-like side effects in certain patients. Theophylline is a distinct type of drug that is chemically related to caffeine. It is a methylxanthine. Some possible mechanism of action of this medication include inhibition of phosphodiesterase, which it does do. This causes increased levels of cyclic AMP. It also is an antagonist at adenosine receptors, just like caffeine is. This is considered a second-line agent for asthma. Aminophylline, which is a strong medication that's given intravenously, is used for severe bronchospasm or for status asthmaticus in patients that have very severe refractory asthmatic attacks. Here you can see the structure of theophylline. It's very similar to the structure of caffeine. Some adverse effects of theophylline include a narrow therapeutic window, which can lead to frequent toxicity. It includes nausea, diarrhea, cardiovascular problems including tachycardia, as well as central nervous system excitation. Metabolism of theophylline is inhibited by cimetidine. As we saw earlier, concomitant use of cimetidine along with theophylline can cause increased theophylline levels. Any cytochrome P450 inhibitor will have this effect. And as you can see here in this patient that's taking cimetidine, which is an inhibitor, the plasma theophylline levels in the patients that are taking the cimetidine will go up. Another medication called cromolyn sodium works by preventing the degranulation of mast cells in the lung. Remember, mast cells release histamine and leukotrienes. Cromolyn is often used in patients that have known asthma triggers, such as pets or cold air. It causes minimal systemic toxicity, but it does have a lower efficacy compared to other medications. Therefore, it's not used as often as other medications for the treatment of asthma. Leukotriene antagonists are another group of compounds that block the inflammatory effects of leukotrienes. These are newer medications, montelukast and zafirlukast. The way they work is they inhibit the cystenyl leukotriene receptor. These medications are given orally, and they're only effective in certain patients. The side effects are very relatively stable in these patients. There's some suggestion that leukotriene antagonists can cause Churg-Strauss syndrome. Xylutanin is another medication that works on asthma. It's a 5-lipoxygenase inhibitor that prevents the conversion of arachidonic acid to inflammatory leukotrienes. This medication is very effective for preventing aspirin allergy, which results from 5-lipoxygenase being activated when COX enzymes are inhibited by aspirin. This medication may elevate LFTs. It's not given very often for patients. A newer medication that's being used for patients with very severe asthma is called omalizumab, or Xolair. And this medication is a monoclonal antibody against IgE. The way that it works is it prevents activation of mast cells by binding to IgE and preventing it from binding to the mast cell in the first place. It's very expensive and new, and it must be given IV or subcutaneously. It's reserved for patients that have very refractory asthma. This concludes our section on medications given for asthma. Our next section will go over medications given for blood clots, as well as antiplatelet medications.